All right. Hello, everyone. I'm here with Dr. Carrie Jones. Thank you so much for being here today. I really appreciate it.
Yeah, absolutely. This is exciting.
Yeah, so let me just give you an introduction and introduce you to our audience. So Carrie Jones has passion and expertise lies in the areas of hormonal, adrenal, and thyroid health. She recognizes that imbalances can occur at any age, and believes that it is important to look at the big picture, such as the appropriate use of lab testing. Dr. Jones graduated from the National University of Natural Medicine in Portland, Oregon, and went on to complete her residency in women's health, endocrinology, and hormones. Later, she graduated Grand Canyon University in the Masters of Public Health program with the goal of doing more international work and health empowerment. Dr. Jones is an adjunct professor at NNUM and regularly consults, lectures, and writes on the topics of hormones, thyroids, adrenals, digestive issues, autoimmune, and more, both nationally and internationally. She's the medical director of Precision Analytical, the world's leading laboratory in dried urine hormone testing. I think I got through that not too bad.
Love it.
So that keeps you busy. So tell us a little bit about what you're doing now these days with yourself.
Oh my gosh, a lot of lecturing, a lot of educating, a lot of travel. I do a lot of international travel about hormones, and I do webinars like this, which is fantastic. I love it to do it with smart doctors like yourself who geek out over this. So It's been busy.
Oh, awesome. And so Do you enjoy what you do?
I love what I do. It's the only thing I know to do. So It's a passion of mine.
It's really important. A lot of the people that we talk to on our forums, and that's some of the first questions they'll ask me is, what are the first things we can do for the adrenals? And I coined, actually, I don't know if you know this, I bought this is how nerdy I am. I bought I guess you can get a patent or a trademark on a name. So stress footprint is what I trademark, because I tell them you need to lower your stress footprint every single day. And that starts with less is more. And that starts with just enjoying what you're doing in life. So, it's really awesome that you do that as well. Are you doing any research in terms of having publications of your own? Do you do anything like that?
Not yet as far as actual publications, but I do a lot of writing. Absolutely. A goal of mine is, eventually to get a hormone, women's health, men's health kind of book out there, even just on the, not even on the grand plane, like published and awesome, but even self-published, just to really help people understand hormones 101, because that's what I get. That's what I understand. And that's what I'm passionate about.
No, that's awesome. So we did, it was probably about a year ago, you and I did another a really great webinar. It was on PCOS and really some of the common myths of having to have just polycystic ovaries to be able to be diagnosed as PCOS. But today, really what I wanted to do was introduce some of the new changes that the lab Precision Analyticals and the Dutch test have added. And so the first one I really wanted to talk to you about was the cycle mapping with so tell us a little bit about what that is and why that's important for women that are having hormonal dysregulation.
Well, and actually this one hits close to home because I'm actually in the middle of collecting my cycle map right now. I'm on, I think, day 16 or day 17 of collection. So I'm going through the whole thing myself. I always do it first before recommending it to others.
Oh, that's cool. Right.
Yeah. But what it is, it's instead of just doing your typical 1-day hormone test, day in the luteal phase, day 19, 20, 21, you will actually urinate on a strip of paper, one strip of paper every morning, basically every day of your cycle. And then the lab graphs it out. So what they do is they graph out your estrogen rise and fall, and then they graph out your progesterone, hopefully rise in the luteal phase. And it's an amazing test because how many women do you know say, I have symptoms all month long, but I know they're hormonal? Or they'll say, I get symptoms around ovulation and around my cycle. Or, I get migraines that seem to correlate with hormones going up and down, or I get weight gain or bloating or anything, or they're just trying to get pregnant. They're trying to get pregnant. They can't get pregnant. They can't figure out their cycle. So when you see it all month long in one big graph, your actual hormones, this isn't temperature, this is your actual hormones, man, you can get a lot of really cool information.
Awesome. So tell us, I know, because I've done that before for other labs. I haven't, full disclosure, done that with you guys. And I do have someone we're working with, so I'm really excited to be talking to you today. But I have done them with the saliva, where they do it for the whole month for the saliva. So tell us a little bit about the difference of the utility of what you're seeing in the urine that you're not seeing in the saliva.
Absolutely. So the great thing about the cycle map is because it's urine, it's not a saliva. They'll urinate on the little strip of paper every morning, which many women find pretty easy because they just have to pee on a strip and let it dry versus having to collect saliva in a tube. But we add on, at the end of the whole month, we do add on what's called the Dutch Complete, where they get all the cool phase 1, phase 2 estrogen detoxification metabolites. So not only do you get to see your estrogen rise and fall in the month, you also get to see how it's going through your liver. Is it going the right pathway? Is it stuck? Is it building up? And then on top of that, you get to see your testosterone and your DHEA pathways. So again, like in our old podcast that we did, we talked about PCOS and the different pathways that give hair growth on your face and hair loss on your head and mood swings like anger. And so we look at those pathways too. And then you get all the cortisol stuff. So you can say, I know you're getting migraines, or I know you're trying to get pregnant, or I know you're having these symptoms. And oh, by the way, here's your whole adrenal picture, because stress footprint, it makes a huge impact on our hormones, right?
Right. Awesome. So, and like you were saying too, we have the pathway planner behind us.
My favorite.
And so when you have a saliva test, you're not looking at those phase 1, phase 2 enzymes. So, you can see where the pathway breaks down and what you can do about it and what the numbers are telling you in real time. So I think that's the benefit too. And also, I don't know, saliva, where's the aha moment for me one time was the saliva represents 1 to 2% of the total, the free fraction of the hormone. Right. Whereas, your metabolized cortisol, is what 95, 96% of the total?
And depending on the literature, it's 80% plus is what we say.
80% plus. Okay.
Yeah. So it gives you an idea of how much cortisol can you make, what's your potential? Can you make it or not? And then the free is how much is free and active. So you may have nothing free, very low levels of free, but you actually have a whole lot of cortisol in total. So it's like, where's it going, right? It's to figure out the big picture.
Yeah, and let's maybe talk about that, because I do get a lot of those questions, Carrie, on, hey, I have already done the Dutch and my free was really high, but my metabolized was very low. Right. Or vice versa. My metabolized was very high or my free was very low. So you can give us some expertise on why it would be high free and low total metabolized.
Great question. The absolute number one reason is a thyroid problem. So the thyroid, when the thyroid slows down, or if you cannot get your T3 into the cells, more of a cellular hypothyroid look, the thyroid will slow everything down. It slows down your metabolism. It slows down your hair growth. It slows down your gut. Now you have constipation. It'll slow down your production of cortisol, and it will slow down your metabolism of cortisol. So you get really low metabolized cortisol. And then what happens is the free cortisol goes, well, I have nowhere to go. I can't get metabolized out. Everything's slowed down, so I'm just going to spin and spin and spin. And so it shows up as free on the Dutch test. It just gets urinated out. So check thyroid if you see that pattern. Yeah,
I did a webinar with Dr. Eric Balkovich, and he was talking. It was I'm sure you're aware of it. He, it was a couple notes for me too, where he looks at the total T3 to the reverse T3, and then the free T3 to the reverse T3, and the numbers he's quoted is total T3 to reverse T3 greater than 10, and then free T3 divided by reverse T3 greater than 0.2. And if those numbers are low, it's exactly what you were saying, where that cellular hypothyroidism, where it's not a glandular problem per se, it's there's no active hormone inside the cell being able to utilize that free, and then it goes really, really high.
And you see this in patients, right? You get a TSH level that's normal, but yet they have all the symptoms. And you're thinking, they look really hypothyroid to me. It's the TSH is just a marker of T3 in the brain, in the pituitary. It doesn't take into account anything that's happening in your tissue. So if your hair is falling out, it's not looking at your hair cells. If you're constipated, it's not looking at your GI cells to see if you can get T3 in there. And so that's the big difference. And it shows up on the Dutch test. We see that cellular, where it can't get in the cells all the time. We see the pattern constantly.
So then on the flip side, what would you see with the high metabolized and the low free, free?
Low free. So if metabolized cortisol is high, then it means either it's upregulated being made, something is, telling the body make tons of cortisol in total, and then the liver is processing it really quickly. So the most common reasons are fight or flight, pain, infection, inflammation, insulin resistance, obesity. Fat tissue can make its own cortisol, hyperthyroidism. Anything that pushes the gas pedal as opposed to the brake will speed up that metabolized cortisol. And then what happens is your metabolized cortisol, your metabolism goes up, so your free cortisol goes down. It's getting metabolized quite quickly. Now,
Right.
the other thing that people forget about is that cortisol rides around on a binding protein on a bus. And so just like with thyroid, with thyroid binding globulin, just like with testosterone, sex hormone binding globulin, you may have too high levels of your binding globulin, your cortisol binding globulin. So sometimes I'll send people back and say, hey, go get more blood work, check your cortisol binding globulin, and let's see if that's the cause of your low free cortisol. And the number one reason for that people forget about is high estrogen. And how many estrogen dominant people do we see? All the time.
Right. So as far as back to the cycle mapping though, so what about, because if the double question, women that aren't having their cycle, so they don't really know why, when the start date is, so would that be recommended for them, and what utility would you get out of it by doing the cycle mapping?
It depends why they don't have a cycle. So if this is a woman who maybe has the Mirena IUD or the Skyla IUD, or maybe she's had an ablation or a partial hysterectomy, so she still has her ovaries, but she's just not bleeding anymore. Great utility, because you can do the Dutch test and we just graph it out for you. Since you still cycle, your ovaries still work, you just don't bleed. But if you have like a menopausal woman, she doesn't have a cycle because she's menopausal, not very helpful, because fully menopausal through menopause generally have pretty low, pretty constant-ish hormones. So you got to take some history. You got to figure out like why aren't you bleeding? If she's irregular, let's say she's trying to get pregnant, but she has PCOS and she's irregular, very helpful then too, because we can still graph out and see, do you get any rise and fall? Do you get anything that happens, and try to act on that?
So what would be the start date then if they're not really sure when their cycle would start, for the ones that are of the younger age that are still, not in menopause?
So they have a couple options. One is they can just start anytime. So they'll start. Let me back up. If they have irregular cycles, so they don't know where they're starting, they can either wait for their next period and then start collecting, or just start collecting and see when their next period comes. The other option is to do an ovulation predictor kit. So go to the pharmacy or the grocery store and buy those ovulation predictor kits. And when it's positive, you're roughly around ovulation. So you would start collecting from there, knowing that's ovulation, and you would go forward about 30, 35 days, because you would know in there you would cycle, but you're not bleeding, like if you had a ablation or the Mirena IUD. And so, but we graph it out either way, so we can at least see if you have a rise and fall. So there's a couple of options.
So how many test strips do you include then in that cycle mapping then?
A lot.
Yeah, am I right?
There's 20 some, I want to say, and then you have the 4 at the end if you add on the adrenal portion and the metabolites portion.
Okay.
So if you add the complete, we add 4 more at the end.
Okay, and then as far as with the information now, so now you're finding different patterns of different, different rise and falls, shortness, length. So what are some of the most common things that you're seeing, and what can be done about those things?
Absolutely. I'd say the number one thing that I see is that people's progesterone falls off short, meaning they ovulate, they make progesterone, but instead of being this nice, healthy, robust curve, It kind of goes up and then and it falls down. And so when we graph it out, we can see, yeah, you have good progesterone for a couple days, but then it crashes. And that's when they say, I have PMS, my breasts are tender, or my periods are heavy, or I'm really moody, or I get migraines. Now, the other thing we will see is that we will see estrogen rise too much, or we'll kind of do this up and down sort of jigsaw pattern, just sort of goes like that. And then the women will say that. They're like, I feel that. I feel one day this way, the next day this way. As I get close to my period, I feel a certain way. And when we graph it out in this big picture, it's literally a big graph that you look at, you can go, yeah, I feel that on that day. That's when it started. Yeah, that's how I feel towards the end of my cycle. Or yeah, that's how I feel at ovulation. I feel terrible. And so then we can address it with, vitamins and supplements and herbs and diet and things like that to say, okay, let's try to get your hormones back on track.
Okay, so a couple fire, and like my brain's going off. Like
no, I love it. Go for it. I'm ready.
So as far as I know, that what are the recommendations for? I mean, these women that aren't doing well with their cycles, they're on hormones. So how are you recommending to do the test? In lieu of the fact that they're doing the hormones, what are the recommendations?
We actually don't recommend. So if they're on any kind of hormone, the cycle mapping will probably not be ideal for them. So especially, even synthetic. So women will go on the birth control pill, but still have hormonal symptoms. The birth control pill shuts down the brain to ovary communication, the HPO axis. And so our test only looks at the kind of hormone that's real. Either you make it or a bioidentical hormone. It doesn't pick up the birth control pill. So we don't recommend it for the pill. And then if you're on, let's say you're on progesterone, you're a woman and you've got symptoms and you take progesterone in the second half of your cycle, what it will do is it will make it look super elevated because you take it every day, especially oral progesterone, which is quite common, or sublingual, where you suck on it, or have little drops that you let dissolve. So we do highly recommend, if you're on hormones, not to do the cycle mapping. Actually, it's best as a baseline.
So how long would they be off of it if they say, well, I just really want to do it? How long do I need to be off of progesterone for me to find out what's going on? Because I've been on progesterone, it's not working. My cycle's still messed up. I want to see what's going on.
So they just stop it right away. So let's say they come see you and they're like, hey, my period's going to start this weekend, but I'm taking progesterone. What do I do? You would say, take your progesterone until you get your period, stop the progesterone, don't restart it, and start the cycle mapping. It's that quick.
Okay, awesome.
You don't have to wait months. Now, with a birth control pill, they have to wait months. So if a patient comes to you and says, I'm on the birth control pill, but I want to go off of it to test my real hormones, they have to go off the birth control pill and have 3 periods, and then they can test. So it's a long time with the birth control pill. Mm-hmm. And the reason for that is the pill is so influential. It's so suppressive. So we have to wait for it to wear off the brain.
Gotcha. Okay. And then what about like thyroid hormone? What would they be doing? What would be the recommendation on that?
Stay on it like normal. Don't stop. Don't change.
Okay, good. Because I don't know. Someone said that they were recommended 2 weeks before. And she said, if I'm off my thyroid hormone for 2 weeks,
No.
Okay.
I could see if somebody said like supplements, not the medication, but sometimes people are on zinc or selenium or herbs for thyroid, and they'll go, I want to know baseline. What are my adrenals and my hormones without this stuff? Sure, then you'll have to stop your herbs and your nutrients for a couple of weeks, but medication, do not stop. Mm-mm.
Okay. Yeah. And then so excuse the pun, cycling back to the original things that we were talking about, you were mentioning that the 2 major patterns would be sort of the progesterone kind of goes and then just drops, and then the estrogen is all over the place. So what would be some of the things you're seeing why that progesterone is doing that? In terms of falling and just dropping? Just
dropping off. Honestly, I think it's a combination, which we've touched on already. I think a combination of stress, of diet, of environmental influencers, chemicals, toxicants, things like that. It's just that when the body makes progesterone, it makes it out of the tissue that's left over when you make an egg. So you ovulate, you release an egg, and this tissue left over is called a corpus luteum or corpus luteum. And that's what makes progesterone. And if it's not strong, if it's not healthy, if it's been exposed to stuff, then it's not going to have the oomph and the muscle to make progesterone for you. So you'll make it, maybe, and then it'll crash and burn early. So believe it or not, I think a lot of lifestyle factors play a role. I think thyroid plays a role. I think stress plays a role. All things that are modifiable, thankfully.
Sure. Absorption and bioflow and then of course the genetics and the super sort of that storm. So then as far as I would imagine the same answer then in terms of the estrogen going all over the place as well. Same thing.
I think it's the exact same thing. I think you just, with genetics, with liver, with environment, with diet, with lifestyle, it's just we can't make the progesterone and we can't process the estrogen, and it just becomes a mess.
Okay, and so where does now sort of the adrenals, which I know, now you have the Dutch complete at the end, and now we're seeing some phase 1 metabolites being upregulated or downregulated, or 5-alpha for is high, and they're aromatizing, or they have insulin resistance, or they have very high free and they're metabolized, which we talked about as low. I mean, all these patterns are showing up, but how is sort of that, how is it being rounded off, so to speak, by that Dutch complete now?
So it just goes to show more to the story, right? More to the picture. So just everything you said, if your metabolized is high, your 5-alpha is high. So for people who don't know, the 5-alpha is the pathway that causes the anger, the irritation, the hair growth in places we don't want it, the hair loss on the head. If they're over aromatizing, they're converting from testosterone too much into estrogen. All of those have the same reasons. 1 is genetics, 2 is stress, 3 is inflammation, and 4 is blood sugar and insulin problems. And it's the same things, I think, that are affecting the health of the corpus luteum and the ability of your liver, of course, to detox, to get the estrogen out. So genetics, blood sugar, inflammation, and cortisol, stress. And along with cortisol is adrenaline, right? Norepinephrine and epinephrine, which doesn't get talked about a whole lot, but huge players.
Right. Yeah. And we talk about that too with, so actually good segue. So now you guys have brought on the organic acid tests. So it's not a complete profile. I mean, it has, the HVA, the VMA, and
5-HI, AA.
Yeah.
And then 6 markers.
The B12, B6.
Yep. And pyroglutamate, so glutathione.
Okay. So awesome. So for those, like what on earth does that mean now for some people where, where they have the concern of aromatization, they have a lot of anxiety, and now potentially gut's not doing a good job. So what utility does that bring to the game now?
Huge. It's great because the 6 markers that we chose specifically line up, give you more information about the Dutch test. So as an example, I just said norepinephrine and epinephrine, or noradrenaline and adrenaline. So that's a VMA marker. And when your VMA is elevated, one of the reasons could be that you're running in fight or flight all the time. And if you're running in fight or flight all the time, which you know, and your listeners know, then I read this super great quote where it says norepinephrine is damaging because it directs away from repair, maintenance, regeneration, and reproduction, and towards things to stimulate, to move you, to get you to like run from the tiger. Except we're not running anymore, right? I mean, not usually. We don't really have tigers and, lions and bears. Oh my, we have bills and we have jobs and we have kids and we have social media and we have politics and things that don't require running, but yet we get that same damage and we lose out on our reproduction or reproductive hormones. We can't repair, so we have more autoimmune. We can't maintain, we get worse. I mean, and it's all ties back to stress. It all ties back to adrenaline. Just on that one marker, it can give you that much information.
Right. Okay. And then as far as the other markers like the 5-HIA and the HVA. So those are just sort of giving us a further picture on sort of
mood,
excitatory and inhibitory stuff.
Yep. You got it. And then of course we have the nutrients, like you said. So we have the B12 and the B6 and the glutathione marker, which tie in really well. Obviously, B6 and B12 are used for lots of things in the body, but on our test in particular, detox. So you are a man or a woman and you have a lot of estrogen in your body and you're looking at your estrogen liver detox. Well, B12, B6, and glutathione play a huge role. So if you are estrogen dominant, male or female, maybe you have low B12, maybe you have low B6, maybe your glutathione is being used up. And now you can put the picture together, like, oh, or put the picture together more. I'm not saying it's a complete picture, but
Right.
more like, oh, I can't get my estrogens out because I don't have enough B12. Okay. Oh, my B6 is low. Oh, my glutathione is getting all used up, or can't recycle, or what have you. So you just get more information.
So what would that show as high markers for deficiencies like the typical organic acids?
It does. So the B12 marker, if it's methylmalonate, MMA, if it's high, and then the B6 marker is crazy named. It's called xanthionate with an X. And then the glutathione marker, pyroglutamate, it's actually if it's high or low. High or low means it's a glutathione problem, right? You can't make it. You're using it up. You can't recycle it.
Right. And same thing for the other markers, B12 and B6, or just when it's high, it's deficient?
Just when they're high. Just when they're high. Yeah.
Okay. Yeah, I noticed you guys, like every time like I get a new report, it's like, oh, there's something new on there that I, like, where did that come from? But, you know, I noticed that you have on the phase 1 where, you know, I joke around, these are bad analogies, but I say phase 1 is sort of like the garbage man bringing the garbage to the curb. Phase 2 is the garbage man taking it away. And usually that phase 1 is sped up. And, you know, if you have garbage more accumulating at the curb that's not being taken away, it starts to stink up the neighborhood. Same things for ourselves. But you guys changed the ratios a little bit. It went a little bit higher.
Well, what we did is we actually opened them up to be the full bell curve. So before we had ideals, right? We had the 16OH, we wanted 20% or less. We wanted the 2OH, 70% or higher. And now we actually have the, you know, within a standard deviation, I think one standard, maybe 2 standard deviations. We have the full range, because what was happening was people said, oh my gosh, my 16OH is at 21% and 20 is the cutoff. I'm going to die. I'm like, no, actually,
right.
You know, it's a little wider than that. It's just, we
Gotcha.
get it.
That's why you did that. So what do you see mostly? I mean, you see an array of stuff, but do you see mostly fast phase 1 and slow phase 2 because of methylation and so forth? Or do you see a little bit of both?
We see a little bit of both. We definitely see slow phase 2. Absolutely. Hands down. But we see a mix in phase 1. I'll see very slow phase 1. I'll see a lot of 4OH, which is the naughty pathway, high, or I'll see really fast phase 1. I'll see all these red arrows in the high marker, and then phase 2 can't keep up. You don't have enough, you know, garbage trucks to take them away.
So what I really like about though the last page, which was like caveman in a fire, is like, oh my God, there's this whole thing now on that last page of the report, or I don't know if it's the last page, but it shows you, you know, what will speed up something if it's slow, or what will slow down something if it's fast. So it gives you great recommendations. So I guess what would be some, you know, just sort of women want to watch this and get some good information about they're really inflamed, they have insulin resistance, they may be aromatizing, they're slow with their phase 2, you know, methylation, they all have MTHFR and other stuff.
Right.
So what are some of the things that you're recommending on that stuff?
Yeah, absolutely. So obviously all the modifiable things that I'm sure you talk to your patients about, of course, you know, obviously diet and sleep, super critical. But as far as supplements, like what can I take? So phase 2, you mentioned MTHFR, and MTHFR is a part of phase 2, but really it's the other gene, COMT, C-O-M-T, right? And it's the M is a methyltransferase. So you need things that have methyl in them. So methyl B12, methyl B6, trimethylglycine, choline, which doesn't say methyl, but choline is helpful. SAMe, the M in SAMe is, you know, methyl. And so it's these methyl movers are what build up your garbage trucks so that you can get all the trash out. And so when people say, what should I do for my estrogen? I'm like, you know what, believe it or not, if you can get that phase 2 moving better, it'll really help that phase 1 no matter what, because you'll just clear the trash. On movers, you got to be careful with, because some women will go overboard on phase 1 and forget about phase 2, men too. And now they have all this phase 1 floating around, all this trash right at the street, and they think they're doing good for themselves, but they forgot to increase the amount of garbage trucks. So the most common thing I'll see all the time for phase 1 is like the supplement DIM. I'm sure you see the diindolylmethane DIM, which is in you know, your broccoli family, broccoli, kale, cauliflower. So women will dose up, and they're like, but I don't feel any better. I'm like, I know, you've just put a whole lot of trash on the street, and You have no choice.
You're gonna start using that. You're allowed to. I'd be very honored if you do. So that's very good.
Funny enough, my analogy is the bathtub. I haven't used the trash. So I always say phase 1 is your water coming into your bathtub, and phase 2 is the ability of your drain. Right?
Okay.
So phase 1 is how fast is your water coming in? What kind of water is coming in? Is it 2 water? Is it 4 water? Is it 16 water?
Right.
And then your drain is your phase 2 is your drain open? Is it clogged? Is it open enough? So that's the analogy that I always use.
I like it too.
I'm loving the trash can. I'm on it.
That's good. We can share. It's a,
Right.
we share.
Let's do it.
So as far as the cortisol awakening response, because I think that's really awesome too. I haven't used that either. I got to be honest. And so I learned about that a while ago, and I do sort of implement, in the morning, people doing some kind of high intensity at low intervals, just if they have a really flat curve. But how are you guys? Is the saliva through? You guys are doing that through?
It is. It is. So here's why. So first of all, people go, I thought you were a urine company. Why do you use saliva? Well, so the cortisol awakening response is literally the first hour of your day. When you are asleep, your brain is telling your adrenals, like, okay, he's going to wake up soon. Let's start in your eye. It takes off. And your cortisol is supposed to shoot way up in the first 30 minutes, if not 60 minutes. So if you don't go up high enough, you're usually pretty tired. And if you go too high, if you overshoot the moon, you're usually anxious or have panic or other issues. And so it's this nice little balance. Because we have to get right when your eyes open, 30 minutes later, 60 minutes later, it had to be saliva. So we have these little swabs that you put in your mouth and you just suck on and then stick back on the tube. So most people can't urinate 3 times in 60 minutes. And most people don't want their blood drawn 3 times in 60 minutes. And so we opted for these little cotton swabs just to make it as easy as possible.
So are people using that as is, or they're using that with the Dutch Complete?
It's called a Dutch Plus. And so it's the Complete plus these cotton swabs that you do in addition. So it's all the dried urine, everything is there, all the same metabolites, everything. But in addition, you add in these saliva markers. So you get more it's more collection, but it's more data. And the whole point of the Plus is to zoom in on the morning. So when you have people who say, my morning is the worst time, I can't get out of bed, I hit snooze a million times, I need 16 cups of coffee, or I wake up in the morning massively anxious, I wake up in panic attack, I wake up with depression, the first 60 minutes of their day are the worst. That's when it's really helpful to just zoom right in, and we check it every 30 minutes to see what's up.
Cool. Do you ever do that like on third shift workers at different times to see if their circadian rhythm's all backwards?
Yep. And we just tell third shift workers, follow your schedule. The instructions will say, you try, morning and 30 minutes and 60 minutes. But if, a third shift worker's morning might be in the afternoon. So I'll say, just do it on your schedule. Don't do it on our schedule.
That's awesome. So what secrets do you have in terms of other stuff that are coming through the pike that you can sort of give us the IPO information on? What's going on there?
Right now we're actually working on somewhere between 5 or 7 more organic acid markers. So we're going to have a little bit bigger panel, all related to the Dutch, and to give you more information. So we have this first set of 6 that are out right now. And then we're looking later, in the year to add on even more to it, just to give you more information and more answers.
Cool. And then just sort of tracking back, you mentioned that one of the reasons for that 5-alpha enzyme being upregulated would be genetics. What SNPs are you seeing that are related to that being more upregulated besides insulin resistance and inflammation?
Actually, if you think about it, so with the 5-alpha reductase, if stress in estrogen, or not estrogen, if stress and cortisol is a reason to upregulate that 5-alpha. So I start to look at the same genes that break down norepinephrine, epinephrine, right? COMT and MAO. So I'm looking at them. So they're not direct to the 5-alpha, but they are definitely, if you have COMT and MAO and you're an anxious person and a stressed person, which means it hangs out longer in your body than the average bear, then your 5-alpha may also be higher as an indirect result also.
Okay, great. That's awesome. I guess the last question I would ask, because I want to be respectful for your time, but I could keep going on and on. I appreciate your time.
Absolutely.
So I'm doing, both, all three: blood, urine, and I'm sorry, I wanted to get with you to go over one of those cases, but
Oh yeah, I wrote you back.
yeah, you did, and I'm sorry. What I find a lot is that the blood values are either normal or really low, and then the metabolized or the urine values are super, super high. And so, and then what the doctors will typically say, the traditional doctors will say, oh, I don't care about the urine, that's not established, and, saliva. So, and I'm just going off of the blood, and that's all we do. And let's yell at that deaf person a little louder and see if that, finally gets heard. So they take more. So what would be, sort of with your expertise, why would that be happening for these women?
Absolutely. Yeah. And, with any testing, you're just looking at a piece of the puzzle. There's no, even the Dutch test, and I'm the medical director for it, there's no perfect test out there. And it has a lot to do with, like clearance rates and detoxification rates and binding globulins in the body. So what's in circulation and what's getting cleared may be a little bit different. It depends if they do it on different times of the day. So sometimes people will do the Dutch test, and we pull hormone off every single collection you do. So when you do it 4 times in the day, we pull hormone off of all 4 markers. Whereas the blood is just a single spot test. So if you got estrogen drawn in the morning and it happened to be low or high, but you do a Dutch test on the same exact day, and maybe your estrogen does rise up, it just takes a little while to get going, we're pulling it on all 4. So you'll get like through the day average will be your estrogen, as opposed to that one blood draw when you went at 9 in the morning to get your estrogen drawn. Same for testosterone. Sometimes people forget they're supposed to get testosterone. Men are supposed to get their testosterone drawn really early in the morning. And so they'll go in the afternoon and they're like, oh, I have low testosterone. I'm like, well, no, you're technically supposed to do it, before 8.
Right.
And which is why in the Dutch test with men and testosterone, we pull it off the morning, the waking sample. And so so a lot of this comes into play, right? It comes in like, when do they do it? What part of the cycle? Was it the same day? How's their detox in general? What are they taking? If they're taking a lot of oral hormone, it goes through first pass, gets kicked out into the kidneys and shows up, of course, high on the urine test. The liver is literally clearing 50+% out of the body. So it definitely, we try to get a lot of that backstory so we can figure out what's going on.
Yeah, no, it's awesome. And you guys really do a great job too when you get the backstory on the back page and they fill out, the questionnaires and it reflects in the report. So awesome job. I'm really grateful. We're friends and I can use you for your information and you can use my analogies. And I really appreciate you giving me the time to share with us and really appreciate the precision analyticals. Awesome lab. I used to do, like I said, saliva testing, and I would see that the free fraction would be high, and then I would give them something to lower it. And then, of course, when I first did my first test through Dutch a while ago, and then I would see, oh my goodness, metabolized cortisol is low on some people that have high, and then I'm only making it lower, and I'm really not going after the why and the inflammatory response and the stressors and everything else. So it's an awesome test, and I really appreciate you guys and you sharing your time with me tonight. I really thank you for that.
Hey, I appreciate it. Anytime. Absolutely. That.
Well, no, absolutely. What we'll do is I would love to do like maybe sort of like a case review with most women, because, they're on the synthetics. I was talking to a lady the other day and she was on 19 years of Premarin, and it's just like, who knows, all the impact that has. And I know you've also mentioned too, like with women and having, the spiral nalactone and the Accutanes and the men with with taking some of the hair and the finasteride and stuff like that.
Yeah.
I mean, you're seeing a lot of issues with that on the Dutch. The Dutch is able to pick that up.
Yeah, and unfortunately, when we do pick it up, but we may not realize it until after the fact if the person didn't write it down. But what happens is often we'll see some crazy looking results. We'll talk to the doctor, or sometimes the patient will write it down. I'm taking Accutane, and then for those who are interested, Accutane can have pretty damaging effects on cells in the hypothalamus in the brain. And if your hypothalamus is damaged, then it can't talk to the pituitary, which means it can't talk to everything downstream, your ovaries, your testes, your adrenals. And I hear it, the more and more and more I talk about Accutane, the more times people say to me, patients or practitioners, oh my gosh, I did Accutane. as a teenager or was in college. I did 2 rounds, I did 3 rounds, and I've never been well since. Or I noticed my symptoms happen then, but I couldn't put it together. And I'm like, yeah, you know, they have no issue. And sometimes it can be pretty, you know, we see it. They're on Accutane. The Dutch test looks terrible. They go off Accutane. They rebound, thankfully.
Yeah. What's your what's your favorite pituitary, whether it be a you know, herbal or it be a homeopathic remedy or something that will really support it? Because usually, you know, with, you know, ovaries and adrenals and thyroid and that, all those axi, is it axi or is it axes? Which one is it? Is it, you know?
Axes? Axes?
Axes?
Multiple axes?
Yeah. What would, you know, the pituitary is just beat down. So what do you like to recommend for that?
My go-to favorite is cordyceps. Cordyceps,
okay, right.
I absolutely love. The mushroom, right? The mushroom cordyceps.
Yeah.
Man, it's one of my favorites. So, and it can be real helpful for the pituitary, the adrenals, the immune system, reproduction. So it's kind of multifaceted, but particularly the pituitary.
It's amazing how it sort of gets back into food, doesn't it? It gets into sort of the super healing powers of food. Well, Carrie, I really appreciate you being here today. I thank you so much, and I look forward to our next time, and have an awesome year, and make sure you chill out and relax and take time to smell the roses as well. So,
absolutely. Thanks, Joel. I appreciate it.
Thank you so much.
All right.